Hi everybody, this is Shannon Finks with the Finks 5, which is a series of presentations meant to cover a therapeutic topic within 5 to 15 minutes. Today's discussion is going to be on point of care testing in the clinic, and it probably will last a little bit longer than 15 minutes because we're going to cover three distinct point of care tests: influenza, strep, and COVID, and also reiterating some skill sets that you may have learned in school, but trying to give you some hands-on examples of how to perform these tests at the patient side in the clinic office, as well as interpretation of those tests and how do you treat that patient that is sitting before you. Learning objectives for this presentation include discussing the most common procedures that are done in our primary and urgent care setting in regards to point of care tests. So we are going to discuss influenza, strep, and COVID-19 testing. We will go through appropriate clinical recommendations based on those point of care tests. And then finally, we will use critical thinking skills to provide evidence-based counseling tips using appropriate communication skills and what medications you may need to order to complete this test to treat approach. I think we all know what the flu is. Flu is caused by the influenza virus, and influenza typically circulates in the United States annually. It's most commonly through the fall and then into the early spring. It is a respiratory illness. It is spread by droplets. And while this past flu season has been incredibly mild as compared to COVID, we sometimes see severe illness and death in those patients who are either immunocompromised, those with chronic illness, those pregnant patients, the very young, the very old. And the CDC estimates that 3 to 11% of the U.S. population is infected per year. And depending upon the flu season, that can cause anywhere from 12,000 to 60,000 deaths every year. And the World Health Organization estimates that 1 billion people are affected each year, with 500,000 deaths globally on a yearly basis. So if you do the math, the mortality from flu is around 0.3% or less. And we'll contrast that with COVID later on, which has a higher annual mortality rate. And it may have been a year or so since we've thought about flu symptoms, but remember that flu can also have very different effects depending upon the patient, and the complications are just as important to recognize. And generally, patients will describe a rapid onset. This came on like out of nowhere. I felt like I was hit by a Mack truck. There can be fever, headache, confusion, respiratory symptoms, nausea and vomiting, diarrhea, the aches, the pains. And flu in general has an incubation period that's fairly quick in turnover. So 1 to 4 days, you can spread the flu to someone else. And in contrast to that, we'll talk about COVID being a longer incubation period and it being more difficult to stay away from someone who's ill, or to recognize that this person is ill with this because of them harboring the virus for a longer period of time and being able to spread virus before you're symptomatic. Do note that flu left untreated can lead to complications, neurological, cardiac, respiratory, pregnancy-related issues if the woman is pregnant at the time she gets the flu, and can certainly lead to rare but important muscle issues like rhabdomyolysis. And so the sooner that we can identify influenza, the sooner that we can begin preventative therapies, the more appropriate treatment of influenza has the potential to decrease these complications. So one of the things that we use in our clinic is a rapid influenza diagnostic test, or RIDT. And these immunoassays can detect both influenza A and B. And what they're looking for is the antigen. And what an antigen is, it's a protein on that virus. And so it's detecting the protein in a respiratory specimen. It does not give you how high the viral load is. It just gives you a qualitative result. So you're either positive or you're negative. And the advantage of using RIDTs is a quick result within 15 minutes. They are pretty easy to perform, but they have limited sensitivity, and that's a negative to their use. And you may be familiar this year with a PCR test, or such as we use in COVID for COVID detection, or even viral culture. Any rapid test is going to have a decreased sensitivity as compared to these more definitive tests. And when you are in the middle of flu season, any test result should be interpreted with caution, because there is potential for false negative, especially when flu is endemic in your area. And the CDC goes on to say that if flu is endemic, it's flu season, it's February, it's January, I've seen a ton of flu, then you don't even have to test. You can go straight to administering drug therapy for presumed influenza based upon the symptoms, because these tests do have false negatives associated with their use. I've provided a guidance reference for the clinician on the CDC website in regards to these tests and how to walk through this, but I'm also providing instructions on our influenza point of care test. And so the test device is, it looks like a pregnancy test, if you will, and there is an extraction well, there's a result window, and you start with making sure that the extraction, or that you're tearing off the tab of the extraction capsule, and you're going to fill the entire contents into the extraction well. Meanwhile, you are doing a swab on the patient, and most commonly for influenza, you're going to do a deep nasal swab or a nasopharyngeal swab. And we'll talk about the technique for nasopharyngeal swabs or mid-nose swabs or oropharyngeal swabs a little bit later. But once you have this sample, then you can insert the specimen swab into the swab stand. You're going to spin that several times. You're going to let it stand for a minute, and some instructions may ask you to spin it again, and then you can discard the swab. And you raise the device upright. You let it stand for 1 to 2 seconds. You can tap it to ensure that the liquid flows into the hole, and then you lay the device back down. Our lab has a series of timers, and my medical assistants start the timer in the lab, walk back to the patient room. They have the timer with them so that we know when the lab is expected to result. And test results are typically every 10 to 15 minutes. You can read the lab just as you would a pregnancy test, and you see the interpretation of the results down here on the lower right-hand column. If you have influenza A, the line for A will be pink, and your control line will also be pink or darker pink. If you have influenza B, you will have a line in front of B. If you have both, you will have 3 lines at the end of that test. If you're only seeing a line at the control, at the level of the control, you have a negative test, and your test is invalid if you don't have a line at the level of control. If you have a line for A or B without that control line being positive as well. And so interpreting this result is important. So clinical decisions with flu, again, any negative test if someone has symptoms is important to consider, and especially if flu is endemic in the community at that time, I would interpret with caution a negative result, and I may go ahead and treat the symptoms not always the test given the probability that flu is more likely. Regardless of that, either if you have a positive point of care test or you're treating the symptoms based upon flu being endemic, the recommendations remain the same. The recovery period may take as long as a week. It may take even longer for people who are immunosuppressed or the age extremes, pregnant women. And all of that at-risk population is also at increased risk for those complications. And so beginning treatment early is best, especially in those at risk. And utilizing treatment approaches that make sense given the patient is important. So starting either Tamiflu or Xofluza within the first 48 hours of symptoms is important. Just another piece of advice on antivirals. They're generally, we want to start them early within 48 hours. The expectation should be in counseling the patient that this is not going to solve all of their aches and pains. This is going to work on the virus to shorten the illness by about a day and to hopefully reduce household transmission. It's best if they're started early, so especially as soon as symptoms start, especially if it's like a family member that is now getting sick, the sooner they get on antivirals, the better. And you can initiate antivirals even greater than 48 hours, especially if that patient has severe or complicated progressive illness. Again, this works to eliminate or to neutralize the viral load, and hopefully it will reduce the risk of hospitalizations and complications of severe disease. There is no data to combine antiretroviral therapy, so we don't give Xofluza plus Tamiflu, in other words. When you look at your treatment options, the two most common, Tamiflu and Xofluza, are utilized in the community for flu. Tamiflu is a neuraminidase inhibitor. Xofluza inhibits viral entry and therefore replication. So different mechanisms of action there. Tamiflu doesn't allow the replication to exit the host cell, and Xofluza prevents and inhibits viral entry and replication inside the cell. The dosing is different, and Tamiflu is a 5-day course. If you are actively treating influenza, 75 milligrams twice daily. If you are prophylacting a spouse or someone in the household or someone who was exposed to them, you would give 75 milligrams every day for 10 days. For Xofluza, it's a one-time dose, and it's based on weight. It's either a 40 milligram or an 80 milligram dose, and if you weigh less than 80 kilograms, it's a 40 milligram dose. If you weigh greater than 80 kilograms, it's an 80 milligram dose, and the prophylaxis is the same as the treatment dose. They're both available in tablet and liquid form, or capsule and liquid form. The Xofluza tablet can chelate, so you want to avoid giving this with dairy products, calcium fortified beverages, cation containing laxatives, and acid supplements. Those types of things you would want to avoid. One of the advantages of Tamiflu is that it can be given in children who are just a couple of weeks old and older, whereas Xofluza is limited to children aged 12 and older. The monitoring for both are unique. The unusual behavior and self-injury is unique to Tamiflu. Of course, Xofluza and any influenza patient you would monitor for secondary bacterial infections. Nausea and vomiting and GI side effects seem to be the most common with both. You can get additional headache with Tamiflu. And Tamiflu is fairly affordable, even at cash pay, but Xofluza is $90 a treatment, and so some patients may not be able to afford the one-time dose treatment. There are other antivirals that are used for influenza. They are much less common. One includes Relenza, which is zanamivir. It's an inhaled formulation approved for kids aged 7 years and older. And then there's Rapivab, which is an intravenous formulation, and it is FDA approved for 6 months and older. These are formulations that are not commonly seen in the community. However, you may come across them in different practice settings. Of note, the Relenza is not to be used in the hospital due to lack of data, and because it's an inhaled formulation, you don't want to use it in patients with severe pulmonary disease or bronchospasm. And unique to it, it is associated or can have Stevens-Johnson syndrome and some neuropsychiatric effects. And then it's contraindicated also in a patient with milk protein allergy. Strep is another thing that we see a lot of in our practice, or have seen a lot of this past year, and streptococcal pharyngitis is one of the most common reasons for people presenting to an urgent care or their PCP in usually the winter months. It can occur though at any time, and it's usually in children, although it can affect all ages. And the pharyngitis is caused by group A streptococcus, specifically Strep pyogenes, and this bacteria, though, accounts for only a minority of cases that present as sore throat. So you have to rule out, when you have a sore throat, is this a streptococcus bacteria, or is this viral? And you really honestly can't tell completely by signs and symptoms, but throat pain that comes on really quickly, that has painful swallowing, that has red and swollen tonsils. Sometimes you will see white patches or pus streaks. They will have swollen lymph nodes. They may have fever, headache, rash, even nausea, vomiting. And the most important thing to realize about strep is that it can cause complications if left untreated. And a couple of the common complications that are no joke are post-streptococcal glomerulonephritis, that kidney inflammation. You can have rheumatic fever, which can lead to painful and inflamed joints, not to mention the heart valve damage that can occur from rheumatic fever. You can have peritonsillar abscesses. You can have scarlet fever from streptococcus. So these are not mild complications from the illness. And just to note, this valvular heart damage, streptococcal pharyngitis or group A strep causes valvular atrial fibrillation. For most of our patients that we see with presentation of AFib, we're thinking non-valvular AFib. The difference is someone has had rheumatic fever in the past, or we are trying to prevent rheumatic fever. Someone with heart valve damage from streptococcus can have a 17-fold increased risk in stroke if they develop valvular AFib later on. So this is a major reason why we treat when we know that someone is strep positive. The physical examination includes looking for swollen lymph nodes. It includes examining the oropharyngeal cavity, looking for tonsillar irritation, looking for those white patches, those enlarged red tonsils, the bumps that are on the soft palate. But it is pretty difficult to tell virus versus bacteria, and so there is a role for diagnostic testing here. Enter in the Centaur criteria, which the Centaur criteria are a way that you can count on your fingers whether or not a rapid test would be beneficial, or if you go straight to treatment. So the things that our nurse practitioner, my husband, even myself are looking for are fever, tonsillar exudate, no cough being present, and then any anterior cervical lymphadenopathy. The age makes a difference. Of course, this occurs more commonly in children. So you get a point for each of those, and you use these points to aid in your clinical decision making. The modified Centaur criteria take that number. If you were a 1, for example, you have a group A strep infection risk of 5 to 10%. They're going to say that's pretty low risk and don't even waste your strep test on them. If you are 2 or 3, the increased likelihood for group A strep is somewhere between 11 and 35%. So this is where you would find value in a rapid antigen test. Or you can treat empirically in some cases if your gut is telling you that this looks like strep, smells like strep, tastes like strep. It probably is strep. And finally, if you have a modified center criteria score that's greater than 4, while a rapid antigen test may be useful, you probably will go on ahead and treat empirically. We will have some people who they just behave exactly like strep. They're febrile, but their test comes back negative. We'll go ahead and treat empirically in some individuals. So because of these guidelines being a little subjective, the practitioner just has to use their clinical judgment and the context of how the patient presents to utilize whether or not they feel that rapid testing is going to aid in their diagnosis. The strep A rapid test that we use is a product from McKesson, who's our wholesaler, and this is a depiction of where you would swab the person in the oropharynx, the oropharyngeal region, and usually we like to get close to the tonsils, on the tonsils, anywhere there is white patches. I try to get a good sample. You will take an oral swab and use a tongue depressor, have them say ah, and get the back of the throat on both sides. This strep test, you'll take then that swab and you'll more than likely go to your lab, or if you have it sitting right beside the patient, you will use a tube, and there are 2 reagents that you'll use. You put 4 drops of each in the reagent. You leave the swab in the tube for a minute, and this tube is plastic, and so it's very pliable. And so after a minute, what I do is I will squeeze the tube and I'll squeeze the swab to make sure that I get everything that I can, all the moisture out of the swab as possible. And then you'll stick your dipstick in and you'll wait 5 minutes. And basically, the dipstick works as a qualitative test. You will have a control line that you're looking for. And then if your test is positive, you will have a second line that indicates that group A strep or the antigen for group A strep was present. If you are negative, you'll only see that line at the control, and it would be invalid if in either case you had no lines, either on the test and the control, or if you only had a line across where the test would be but negative on control. So this was a patient that I took care of. That was probably the first strep test that I actually performed. And she was a 52-year-old female. She came in, she had fever, she had sore throat, she had swollen lymph nodes. She knew how this felt. She told me that she always gets strep and it feels just like strep. And so we did a rapid strep on her. And I hope that it was performed with good technique. This particular test had a sensitivity of 97% and 95%, and the test results are shown below. So just so we're all on the same page and we're grasping the concept of how to treat strep, this question asks, what's the likelihood of her having strep caused by group A streptococcus? So is it 3%? Is it 5%? Is it 95%? Or is it 97%? And hopefully you have correctly identified that this is a negative test. And with a sensitivity of 97%, this test is going to correctly identify the 97% of the positives. but that leaves a 3% chance that she could have strep and it was not correctly identified. So you use your sensitivity and your specificity in your clinical diagnosis, and it's not all or nothing. This is not a 100% likelihood test. What we did with her was we told her that we didn't feel that she needed treatment. We thought it was viral because the strep test came back negative. But we also told her that because she'd had strep before and it feels just like it, to keep in touch with us. And if she needed to on the next day, to call us and come back and we would do another strep test. Well, I learned very quickly that if you offer that, patients will take you up on that. And so she was no better. She came back into the office the next day and in fact, indeed, tested positive the next day. And so in hindsight, I think I probably would have and should have used my gut instinct saying that, this isn't 100% sensitive. There is a likelihood that this is missing it. But I saved a day of antibiotic therapy, and then the next day when she came back positive, we went on ahead and treated her. Treatment guidelines are published by the Infectious Diseases Society of America. The particular guideline that I'm referring to was published in 2012, hasn't changed since then, but treatment considerations, either empiric or after positive testing, include either a single intramuscular injection of benzathine penicillin G or a 10-day course of amoxicillin or Pen B. In the pen allergic patients, options include either a 10-day course of cephalexin, clindamycin, clarithromycin, or a 5-day course of azithromycin. And you should use your local antibiograms to consider the likelihood of compliance, cost, and choosing the most appropriate antibiotic, utilizing the best antibiotic stewardship that you have at your fingertips. Counseling tips for group A pharyngitis include completing the antibiotic course. Don't stop, even if you feel better. And you can also give adjunctive therapy either with an analgesic, an antipyretic, for moderate or severe symptoms or fever. Remember that aspirin should not be used in anyone less than 18 because of Reye's syndrome. And we don't typically recommend corticosteroids. At this point, they are not without risk themselves. And so typically the pain for pharyngitis is not that bad, and we can get away with or over-the-counter anti-inflammatory agents. There is no vaccination for strep, therefore we want to be teaching patients to wash their hands, cover their mouth, don't share personal items, particularly if someone in the household has strep. And elective tonsillectomy is an option. Usually these guidelines say when you have greater than 7 infections in a year. Of course, I've seen ENTs actually take tonsils out much earlier than 7 infections in a year, but the object here is to reduce the frequency and severity of strep throat. Many children stop having strep as they get older and their anatomy changes a little bit. But we do know that some people carry strep, they're group A strep carriers. And so someone who still has that bacteria, who's no longer being treated and no longer has symptoms, you may consider an antibiotic course or even elective tonsillectomy in those individuals as well. That, again, is beyond the scope of this discussion, but I refer patients who can't seem to clear it to ENT. Of course, the risks with tonsillectomy include anesthesia and bleeding, so it's not the answer for everyone. Patients with recurrent pharyngitis and laboratory evidence of group A strep may be chronic carriers, and they may be subject to either having repeated viral infections, bacterial infections. They may pass it on to others. And you can consider treatment. Antibiotics aren't for everyone, but you can consider treatment. Generally, if there is any question of rheumatic fever, any of those complications like post-streptococcal glomerulonephritis, Anytime there's an outbreak of strep, either in a family or a nursing home, when the family has great anxiety, or when tonsillectomy is being considered only because the patient is a chronic carrier. And antibiotic regimens, these other antibiotic regimens have been shown to substantially eliminate chronic streptococcal carriage, more so than other treatment options. So you'll notice clindamycin, you'll notice augmentin, you will notice rifampin being combined with a penicillin, and this table is a part of the Infectious Disease Society of America guidelines on strep. We are now at the point of this program where we're going to talk about a little virus called COVID. I'm sure you've heard about it. Of course, this is the virus that was responsible for the global pandemic of 2020, SARS-CoV-2, and as of the date of this recording in May of 2024, we have over 704 million cases worldwide and over 7 million deaths. And in the United States, we have 111 million cases with 1.2 million deaths. And the mortality of this virus has changed over time. In the beginning of the pandemic, pre-vaccination attempts, endemic status, the mortality was more around the 2.1% range. And so thankfully, we are at a point in time with a much lower mortality. However, just to put this still in perspective, remember that influenza, the mortality is 0.3%, and it can still kill up to 60,000 individuals per year. So COVID still is 3 times, if not more than that, the mortality of influenza. And so it still presents a threat. And I want to emphasize that a pharmacist's role during a viral illness, during a viral season, is so very important. We have test to treat strategies. We can administer drug therapy for patients who are positive for COVID, and because there are still quite a few people who are at risk, this makes the pharmacist role that much more important. And of course, COVID is not going away. There are viral strains that are continually adapting. And hopefully, though, we will remain at a time frame like today where the mortality is relatively lower than at the beginning of the pandemic. These slides throughout the remainder of our talk today were recorded at different times in the pandemic, and instead of re-recording every single slide, I've only chosen to update those slides that have updated information. So you may hear me say what I've learned over the past year, and of course I have slept since then, and it has been 4 years since the beginning of the pandemic. So take dates, bear in mind that they may be slightly off, but I've updated this slide set as of 2024 to give you the most up-to-date information. So since COVID has not gone away, let's talk about your options for COVID testing. When you're testing for an active infection, you have basically 2 options. PCR testing, you probably remember from the pandemic. This was the gold standard, and this was the most sensitive test for COVID. It gives you, or it could give you, both a qualitative and a quantitative response, meaning it's going to tell you, yes, you're positive. And when you are positive, your lab can provide you with information such as a cycle threshold score of how much virus is present within that sample. It was extremely valuable to us and allowed us to publish a paper utilizing counseling techniques based upon how much virus is present. I'll share that paper with you at the end of our discussion. But we don't use PCR testing as much anymore because it is a send-out lab. You do have to send it to your partner lab. It is not CLIA waived, meaning you can't do it in the clinic with the patient next to you. Rapid testing, however, is available in the clinic. There are two forms of rapid testing, both the antigen test, which is a mid-nair swab, and it is less reliable than the PCR test, but it will give you only a qualitative result, meaning are you positive or are you negative? But it's very quick to return. It's 15 minutes and you know whether or not you're likely to be positive or not, whereas PCR testing requires hours to sometimes days to return because it's dependent upon your lab partner. You can also test for antibodies after infection. A couple different ways to do that: serum and finger stick, the serum being the more reliable. And I will say that this was popular when people were trying to travel during the pandemic. I'm not sure how much clinical value it holds anymore, but if you are curious to know, do I have antibodies to the virus or do I have antibodies from my virus, antibody testing is an option. And so, for example, to the virus, when you develop IgG, IgA, IgM antibodies to the virus, you actually develop antibodies to the nucleocapsid protein. That is the purple strand there, kind of on the surface of the virus, that purple and green. And so you can specifically test for antibodies to that nucleocapsid protein. When you give a vaccine, however, you're giving your body the instructions to develop an immunity towards that spike protein. So they're actually different. You can test for antibody response to the vaccine through that spike protein. So when you're ordering serum testing, if you do find that a patient values this, make sure you know what you're ordering. Are you ordering it to the virus or are you ordering antibodies to the vaccine? And the finger stick tests, while they are convenient in the clinic, they are not as reliable as serum testing. So just in summary, this is a visual which test for which time. If you're measuring active infection, you're going to want to do a viral RNA, that's your PCR testing, or a rapid PCR, and then the viral antigen, you can do a rapid test in that regard as well. You're looking for the proteins on the surface of the virus there. And then after infection, you're measuring IgG and IgM. If you have trouble remembering which one comes first, IgM, you get IgM the minute you get it, and you develop IgG after the virus is gone. So IgM is the minute you get it, IgG after the virus is gone. Typically, for most other viruses, IgM and IgG are going to occur much quicker than COVID. COVID IgM is not even going to start to detect positivity until 7 to 10 days after infection, and that's slower than other viruses. And IgG will last for weeks at a time. Anytime you're going to perform a test, particularly in a COVID setting, well, actually, for any illness, you're going to want to understand the sensitivity and the specificity for your test, because those false negatives that occur, you're going to want to know your likelihood of missing an active case if a false negative were to occur. But I've found that having simple discussions on why the rapid test could be negative for COVID, but you have symptoms, so I still want you to quarantine, and I'm going to get a confirmation PCR to make sure. I've found that an easy, simple discussion of sensitivity and specificity make all the difference in the world. So the sensitivity is going to look for those positive cases that will correctly test positive. And so a highly sensitive test will generally have a really low false negative rate. But if the virus is not endemic in the community, it will run a higher risk of false positives if the test specificity is low. The specificity is the ability for that test to rule out negative cases. So negative cases are correctly identified as negative. And a highly specific test will generally have a low false positive rate. But it may run the risk of a false negative if the sensitivity is low. So ideally what you're looking for is a test that has a sensitivity and a specificity that are both in the high 90s. So no test is 100% sensitive and 100% specific. But when it comes to COVID testing, at least, the nasopharyngeal swab on a PCR test is pretty darn close. And I know that we all have heard horror stories. We may have actually even experienced a horror story with a nasopharyngeal swab. But I want to talk you through our testing and just the technique in case if you have never actually performed a nasopharyngeal swab yourself. So the first thing that I want to point out is that there is a difference in size between a nasopharyngeal swab, you see the tip is very small, and an oropharyngeal swab, which the tip is more similar to the end of a Q-tip. And it makes a big difference. My lab supplies my swabs, and so I'm very thankful that they supply the materials needed for me to get the most accurate test. And I've had students who I've trained on nasopharyngeal swab techniques tell me that they were either swabbed with an oropharyngeal swab in their nose or they don't have the right testing utensils at their places of work or in where they were volunteering for nasopharyngeal swab. So first, your equipment makes a huge bit of difference in terms of tolerability of the test. Our noses were built automatically to keep marbles from being stuck up them. And you will see along the nasal passage here at the top right that there are turbinates that are natural. All noses are different, and sometimes the turbinates are very large. Sometimes I don't even feel them at all when I insert a nasopharyngeal swab. But the object is to stay along that middle of the nose, that septal wall, so that you avoid getting snagged on a turbinate. But it's not, because this picture is not 3D, it's vertical. Really what you're aiming for is to go back horizontally in that oropharyngeal passageway where the nose and throat meet. And so in both the bottom pictures, it shows you the length and the position of the swab to naturally glide back. So when I teach my students how to do this, I stay on that septal wall, but I never go up. I go straight back. And your head does not need, the patient's head does not need to be tilted back. And in fact, if you tilt back too much, you have less of a chance of getting in the true nasopharyngeal passageway. I will say that each lab will have a different validation for the different places and locations. So, for example, our lab prefers nasopharyngeal location because it has a greater sensitivity and specificity. They do have EUA for mid-nasal, and they also have EUA for an oropharyngeal swab, and I will typically reserve an oropharyngeal swab for someone who has symptoms like
a
sore
PCR
throat.
result from a lab-based test. So the patient gets this back in their portal. It is positive or negative, so it's qualitative only. And there is, across the United States, every lab has different reagents, different equipment for their PCR testing. And so the FDA sets the level of positivity across all labs at 5 viral copies of RNA. That is ridiculously small. That's one of the reasons why a PCR can pick a needle out of a haystack. It's just super, super sensitive. With that, though, comes some interpretation of this test where some patients may say, well, I don't have any symptoms, I'm not positive. Well, you can learn a little bit more about their positivity through partnering with your lab through a score called the cycle threshold. It tells you how much virus was present within that sample. And if we ever find ourselves in a pandemic again, using a cycle threshold score was very helpful for our patients to understand, yes, you're positive, but your level of virus is super, super low. Let's retest you in a couple of days versus, oh, I am very sorry, your level of virus is extremely high. You need to quarantine from your family because of the high risk of transmission. It gave us a lot more information than just a yes or no answer. This is our paper where we published in the American Journal of Medicine Open our interpretation of the cycle threshold and how we utilized that in patient counseling. And again, for those of us who remember the pandemic and with the initial quarantine guidelines, you had a lot of angry businessmen saying, I can't quarantine for 14 days. What the heck is going on? And we were able to utilize some objective information. And patients didn't fight us. When their viral load was really high, they accepted their positive score. And this just shows how partnering with the lab and using logical, objective information with your PCR test became very important to us during that time frame. And lastly, just a final plug, this is an example of how pharmacists can be involved in the interprofessional team. We're a vital role in helping patients understand their illness and how to best treat it and how to best quarantine when it is appropriate to do so. Antigen testing for COVID is the most popular because it's inexpensive and you get a result within 15 minutes. Antigen testing, again, is looking for that protein on the surface of the virus. This particular testing utilizes lateral flow. It's like a pregnancy test where you provide the sample with a little bit of liquid. It flows over the test strip and then will change color and result in an interpretation very quickly. This is an example of our most common antigen test in the clinic. We use the Binax card, where on the left it describes that when you get the nasal sample, you are going mid-nares and you're also swabbing both sides of the nostril. And you can allow a patient to help you swab if they are hesitant, but our medical assistants and our pharmacy students are usually the ones who are doing this testing. You would utilize gloves in this case, just swabbing gently and carefully inside mid-nares on both nostrils, and then taking that sample with the card open. You would put 6 drops of reagent into the top hole, and then you would insert the swab into the lower hole, and you would rotate that several times, up to 10 times, and then you close the card and let the card sit there for 15 minutes. You make sure that the card lays flat because it is a lateral flow design, and your result will appear positive or negative within that time frame. Sometimes a positive will appear very quickly and you don't have to wait the entire 15 minutes, but you would want to wait an adequate amount of time before telling someone that they're negative. You want to give that the full testing time before you influence that result.
Now I'd like to transition to the outpatient management of COVID-19. And symptom management is really the first step. Treatment of symptoms include over-the-counter analgesics, antipyretics, antitussives, headache medicines, medications that are used for myalgia and cough. Patients should be advised to drink fluids regularly to avoid dehydration and to rest. And they should be educated on when to let their provider know if symptoms were to worsen. And many clinics can follow these patients by telehealth to manage their dyspnea and to make sure that their symptoms aren't progressing. But the main goal of therapeutic management for these non-hospitalized patients is to prevent progression to severe disease and to prevent hospitalization and to prevent death. And there are several factors that affect the selection of these agents, and they include the clinical efficacy of the drug. So for example, Paxlovid has the best efficacy as an oral antiviral to prevent that progression to severe disease. But it also depends upon availability of the agent that is prescribed. So, for example, availability and feasibility. Remdesivir is an antiviral that's recommended by the NIH COVID-19 treatment guidelines, but that is not for everyone because it requires a parenteral IV to be administered 3 days in a row. We also want to look and screen for potential drug-drug interactions, particularly with Paxlovid. We cannot give Paxlovid with certain drugs, and we have to be very careful about the timing of co-administration of some drug interactions with moderate significance. We want to look for pregnancy status and time of symptom onset. And then, of course, COVID treatment depends upon what the circulating variant and subvariants are at that time. So, for example, early on with the Alpha and Delta variants, people stood in line for hours to get monoclonal antibody infusions, and those antibody infusions are not effective against Omicron and current variants in 2023. I've included for you the COVID-19 treatment guidelines that is constantly updated by the NIH, and this is a website that I go to regularly. I also will show you the link for the Paxlovid drug-drug interactions because this is something that you will want to pay attention to very closely. When you're thinking about who needs antiviral treatment, you're thinking about those who are at highest risk. And who does that mean? Well, typically it's older patients, so that starts at age 50, but especially in those who are aged greater than 65 years. Those who may be immunocompromised and are unlikely to have an adequate immune response should they get infected with COVID. Someone who has never been vaccinated or someone who hasn't completed their vaccination series, if it has been a prolonged amount of time since the most recent vaccine dose. Those with high-risk conditions such as obesity, diabetes, COPD, cardiac or kidney disease, and of course we know that racial and ethnic minorities have a higher risk than those white counterparts. The COVID-19 treatment guidelines are kept up to date by the NIH, and they were most recently updated in April the 20th of 2023. They again recommend symptom management for all patients. They recommend against the use of systemic corticosteroids, specifically dexamethasone, in the absence of another indication. This is not a ruling against inhaled corticosteroids, which have been incredibly helpful in patients with shortness of breath and cough in the outpatient setting. They're preferred antiviral therapies that are used only in those high-risk individuals to prevent the progression of severe disease, hospitalization, and death include Paxlovid first, remdesivir second, and then molnupiravir for an alternative therapy. And these therapies and their rationales can be found on the NIH website that I have provided on this slide for you.
This information has been updated in 2024. And again, those patients who are not hospitalized, don't require oxygen. This set of guidelines goes through who is considered highest at risk, why we don't currently recommend oral dexamethasone. That does not include inhaled for those people who are severely coughing. This does give you additional information on the immunocompromised patients because they are very high at risk and have evidence of ongoing viral replication. You may use these therapies for a longer period of time than the general population. We don't avoid Paxlovid just because we're worried about viral rebound, which can occur after you stop taking Paxlovid. This gives you a link for the drug-drug interactions that you must screen for before prescribing and counseling a patient who is about to receive Paxlovid. It does also reiterate that molnupiravir is not recommended for patients who are pregnant.
I wanted to also include cutoffs for creatinine clearance, and again, in order of preference, this is the current 2024 therapeutic guidelines for management of non-hospitalized patients with mild to moderate COVID-19, provided that they are not requiring oxygen. And again, the EPIC-HR trial found that Paxlovid reduced the risk of hospitalization or death by 89% compared to placebo in unvaccinated, non-hospitalized adults with confirmed infection. And so that's why Paxlovid is mentioned first. Remdesivir is there. It requires a 3-day a 3-day infusion, 3 consecutive days, and then molnupiravir is the third choice. We need to talk about Paxlovid for just a moment because it is a very unique drug to dispense or to prescribe, and the counseling on giving Paxlovid is very important. Of course, it's a combination of nirmatrelvir with ritonavir, and the ritonavir, of course, being the very strong, potent cytochrome P450 inhibitor, 3A4 inhibitor, as well as a P-glycoprotein inhibitor. And it also may increase blood concentrations of certain concomitant medications, which is why it is so very important to screen for drug-drug interactions and to know how to navigate when someone is receiving Paxlovid. The dosage for Paxlovid is 300 milligrams, which are 2 of the 150 nirmatrelvir tablets with 100 milligrams of ritonavir in normal renal function, but that dosage is reduced in someone with moderate renal impairment. So you're going to reduce the dose to 150, 100 over the course of 5 days in those patients who have an estimated glomerular filtration rate of somewhere between 30 and 60 mils per minute. I've given you the link for the NIH guidelines that gives you access to the drug-drug interactions with Paxlovid. And I think it's really important to understand that many commonly used medicines can be safely co-administered with Paxlovid. Drugs that you might commonly see given with Paxlovid that are okay to continue are those over-the-counter allergy medicines, azithromycin. You can give pravastatin, you can give Zetia, and you can give those over-the-counter antipyretic medications without regard to clinically significant interactions. But there are some interactions that can be even life-threatening or very serious toxicities. And CYP3A4 inhibition with ritonavir occurs very rapidly. This occurs within the first 48 hours. And then after treatment is completed and the ritonavir is discontinued, 70 to 90% of this inhibition resolves within 2 to 3 days. So some of these interaction categories, you can temporarily withhold a concomitant medication. So you're looking at some of the anticoagulants like rivaroxaban or even ranolazine or ticagrelor. Atorvastatin, lovastatin are included, and rosuvastatin in this category. And so they're common medications that you have to counsel a patient through temporarily withholding if they meet the criteria to use Paxlovid in them. There are 5 different categories in this particular guideline. And I just can't emphasize enough to go to the guidelines every time, because this list is continually updated, and it will give you advice on how to talk a patient through these clinically relevant drug-drug interactions. And of course, as a pharmacist, before prescribing or giving Paxlovid to an individual, you really need to carefully review the patient's concomitant medications, including over-the-counter and herbal supplements, because St. John's wort, of course, is on this list, just as an example. I just want to spend a moment talking about viral rebound, which doesn't happen often, but both the studies using Paxlovid and molnupiravir have shown that there is an increased risk, or probably to the tune of 10 to 15%. Not great risk, but it can happen, where you've utilized the medication for 5 days, and then after the patient stops taking that medicine, their symptoms reoccur, and that is considered a viral rebound. And we used to say, you have to go back into quarantine at that time. Since quarantine recommendations have changed, it is now considered that you need to be fever-free for 24 hours. And so if your symptoms do recur and there is viral rebound, you need to return to quarantine at least until you're 24 hours fever-free. Incidentally, though, this can also occur in patients who've not received treatment for COVID-19. So viral rebound could be your own immune system that is working against the virus, and then the virus just rebounds. And so this is not only with drug therapy. And the guidelines state that concerns about viral rebound should not be a reason to avoid using antiviral therapies, especially in those high-risk patients when their use is indicated. And you may be intimately aware of the Test to Treat initiative that was first launched in March of 2022 by the Biden-Harris administration. And basically, this was aiming to help people quickly access these life-saving treatments for COVID-19. And this initiative is available at thousands of locations nationwide, not without controversy from our physician colleagues. The AMA is quite upset about this. However, this is very important. It includes pharmacy-based clinics, federally funded healthcare centers, long-term care facilities, community-based sites, and these federally supported test-to-treat sites, which reach vulnerable communities, include some of the nation's largest pharmacy chains. And state licensed pharmacists can prescribe at these testing centers or these test-to-treat sites Paxlovid to individuals who meet certain requirements. So in summary, I am really sorry this took a lot longer than 5 to 15 minutes, but it made sense to include influenza, strep, and COVID
all in one presentation because we're really talking about the value of point of care testing here and the ability to quickly identify infections so that we can appropriately initiate treatment very early. The end result of that being improved patient outcomes and reducing complications that occur from these viral or bacterial illnesses. And understanding the benefits, but particularly the limitations, such as sensitivity and specificity of these tests, really allow for meaningful patient interactions, and it allows us as pharmacists to problem solve. And for those of you who are students about to enter in our rotation, you will see and you will participate in all three of these as patients present to our clinic. And I will pair you with either a medical assistant or a pharmacist so that you can understand and gain hands-on skills in each of these point of care tests.